everyone. Welcome to the University of Toronto Joint Centre for Bioethics Seminar Series. I'm Andrea Bianchi, and I'll be the moderator for today's session. Our speakers are Daniel Buckman and Sarah Levitt, and their seminar is entitled Towards a Palliative Psychiatry, Ethical Reflections on Futility. Before I introduce today's speakers, I'd like to let you know that the seminar is being recorded. This lecture, along with other archived lectures, can be accessed through the Joint Centre for Bioethics website. The format of our seminar is a presentation by our speakers, followed by a facilitated discussion period. We would like to take a moment to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. We also stand in solidarity with the ongoing protests against racism and systemic discrimination. Now it is my pleasure to introduce today's speakers. Dr. Daniel Buckman is a bioethicist and independent scientist at the Center for Addiction and Mental Health. He is also an assistant professor in the Dalla Lana School of Public Health at the University of Toronto, a member of the University of Toronto Joint Centre for Bioethics, and an affiliate scientist in the Krembil Research Institute at the University Health Network. Daniel's primary areas of research interest include ethical issues related to mental health, substance use, and chronic pain. Themes related to stigma, identity, moral responsibility, and compassion feature prominently in his work. Some of Daniel's current research interests are in the areas of ethics of machine learning and big data in mental health, neuroethics, and psychedelic-assisted mental health care. Dr. Sarah Levitt is a psychiatrist working in the Center for Mental Health and the University Health Network. She is the co-medical director of IMPACT, UHN's assertive community treatment team, as well as an inpatient psychiatrist. Dr. Levitt completed her residency in psychiatry at the University of Toronto after graduating from U of T's medical school. She then was the inaugural Brain Medicine Fellow at the University of Toronto, completing additional clinical training in neuropsychiatry. Dr. Levitt has an MSc, Master of Science from the University of Oxford in the history of science, medicine, and technology. Her thesis work focused on the development of operational criteria to define psychiatric diagnosis. Her academic interests include the history and philosophy of psychiatry, as well as developing pathways for palliative care for individuals experiencing severe and persistent mental illness. We look forward to your presentation.
Thank you. Thanks so much for having us today. So as mentioned, we're presenting on the title of our presentation is Towards a Palliative Psychiatry, Ethical Reflections on Futility. And I'm really happy to be presenting with Daniel today. This presentation is based on a paper that we wrote and was recently published in the Journal of Medical Ethics called Applying Futility in Psychiatry, a Concept Whose Time Has Come. And I'll talk a little bit about what we will be discussing today in just a minute. We have no conflicts of interest. And we want to acknowledge a couple people who helped really push our thinking on this topic: Rachel Cooper, Dr. Suze Burkout, Deanna Chakos, and Andrew Lustig. And just to note that this research was supported by the Brain Medicine Fellowship at the University of Toronto, which I was lucky enough to be the first Brain Medicine Fellow this past year. Next slide. So in terms of what we're going to be talking about today, we'll start by defining futility in healthcare settings, and we'll also discuss the strengths and limitations of applying the concept of futility to psychiatric practice. And I want to note that this paper and this presentation came out of discussions that Daniel and I had towards the end of my residency training in psychiatry. I recently graduated, and I came to him wanting to do an ethics elective because I had noticed over the course of my 5-year training that I was sometimes getting into situations with patients where I felt like I didn't really have that much more to offer. I was still witnessing a lot of suffering, and I was feeling kind of stuck about what to do next. And I felt increasingly like I had a moral or an ethical obligation to actually address this with patients, but I didn't have a language or know how to do that. And so Daniel and I started to talk about this idea of futility in psychiatric practice. And our final point today will be talking about sort of trying to address those questions I had come to him with, and talking about how the concept of futility can support the development of a practice of palliative psychiatry. Next slide. So we'll start by defining futility in healthcare settings. And I love this quote, which came out of the futility literature, which says that we need to treat futility as the courts treat pornography, acknowledging that while it cannot be defined, we know it when we see it. And that certainly seems to be the unspoken rule amongst healthcare practitioners. Next slide. However, despite the fact that it's difficult to define, that has not stopped people from trying to do so. And there's actually a really large literature on futility in medicine in general. And there's sort of three main definitions of futility that have emerged through the literature. The first is something called physiological futility. So that's the concept that an intervention is futile when it's not going to make any sort of physiological or biological difference. For example, if someone was having a heart attack and I said, oh, here, have a cup of orange juice, that could be considered a physiologically futile treatment because I have no biological mechanism to think that that orange juice is going to change anything about that person's heart attack. The second definition of futility is something called quantitative futility. So quantitative futility takes a numbers-based approach and essentially says that an intervention can be considered futile if the last 100 times the practitioner attempted it, or the last 100 times it was described in the literature, it did not work in whatever sense they were hoping it would. So essentially, it's a less than 1% chance of working, then something is futile. The final definition of futility that emerges is something called qualitative futility. So the principle behind an intervention being futile, if you define it in this way, is that it's not, if you pursue this intervention, it's not going to produce the quality of life that you are hoping for from that intervention. And on the next slide, I'll address some of the problems with these definitions. And the major issue with all of these definitions is that none of them are actually value-free. So with physiological futility, it's essentially saying that biological homeostasis is more important than any other quality that an intervention could produce. And we don't really have a good ethical reason to understand why we should favor the biological result over anything else. Quantitative futility doesn't offer us an ethical basis for why less than a 1% chance is what constitutes futile. It's sort of a perhaps reasonable, though arbitrary number that the literature has come up with to define futility. Finally, qualitative futility is problematic in that while it says the intervention is not going to produce the kind of quality of life that you're hoping for, it's unclear who gets to choose what constitutes quality of life. Is that based on the patient's decision, a caregiver's decision, the healthcare practitioner's decision? There's nothing to really guide us around how to use the idea of qualitative futility and whose opinions we should be considering in that definition. Next slide. So some other thinkers have tried to further to address these problems by trying to further define when an intervention might be futile in medicine. So Mohindra is one of these writers, and Mohindra argues that really we're thinking about this in too complicated a way. He says that futility is really a single point, and an intervention can only even be considered to be futile if it is net neutral in terms of its risk of harm or risk of benefits. And his argument is essentially if an intervention is likely to be net beneficial, even if it's not that beneficial, as clinicians, we have a moral obligation to offer that treatment. Conversely, if the intervention is known to be net harmful, even if it's only a little bit net harmful, we have an obligation not to offer that intervention because we have the duty to do no harm. Therefore, the only types of interventions that could even be considered futile, where we're trying to make this judgment about whether or not to offer them, for example, is something that is net neutral with respect to risks and benefits. And really, those interventions are hard to come by. There's very few things in medicine that aren't going to cause any benefit or any harm. Next slide. So Mohindra suggests that we start to actually shift our thinking around futility to actually acknowledge that values are playing a role in how we're looking at whether or not an intervention is futile. And his argument then goes that while the defined intervention may modify the probability of benefit or harm, if there's still likely to be close to a net zero gain on either side, then maybe you start to introduce your own values into why you might consider an intervention to be quote unquote useless or not going to work, again, towards whatever goal you're hoping for. And he says we need to acknowledge that those valuations can be based on morals, they can be based on finances, they can be based on the kinds of symptoms that someone's experiencing. And he really makes an argument that we should be considering the patient's perspective in that valuation, and they should really be making those decisions for themselves. Now, there are a couple of challenges to this definition. The first one is that with some interventions, patients may not know how they value it until after the intervention has already been done. So for example, you could have a patient who prior to becoming unwell or something else says, you know, if I were to become super sick, I'd want CPR, I'd want intubation, I'd want ICU transfer, et cetera, et cetera, et cetera. And it's only after they've gone through all of that, because they've become unwell and they realize that they didn't get the quality of life that they wanted, or they're left with significant morbidity, that they realize, actually, like, I don't know that that was something that I valued or that I actually wanted. And then it makes it really tricky to understand how we apply value futility to medical decision making if someone's only going to know in retrospect how they value something. The other challenge to value futility is the idea that for some patients, some families, the act of intervening in and of itself is what holds value. So even if they have a clinician say, you know, I really don't think that this is going to achieve your goal, like this intervention is possible, but I don't think it's going to achieve your goals. They say, no, like I want to try absolutely everything. And that sort of undermines how you could use futility in medical decision making. And I think that's where we often in healthcare settings see frustration between clinical teams and patients and families, in terms of clinical teams really feeling like something is not going to be helpful and patients just saying they want anything at all. And so it really can create some conflicts. Next slide. So Pope, who's probably the biggest writer on futility, says that one of the ways that we can start to resolve a bunch of these conflicts and resolve some of these challenges is to think about futility not so much in terms of something being useless or not going to work, but rather as this idea of potentially inappropriate treatment. And his argument is basically, if futility is taken at face value, it means that an intervention is useless. If an intervention could have any physiological effect at all, we can't say that it's useless. So potentially inappropriate treatment might be a more helpful clarifying concept to address what we mean when we say a medical intervention is futile. And that concept acknowledges that a treatment has a physiologic effect, but it will not alter the quality of life in the way that the team, the patient, the caregiver, a combination of everyone is hoping for. And the ways that you explain why a treatment might be potentially inappropriate is to use those ideas of qualitative and quantitative futility. So to frame it in terms of quality of life, and also in terms of your suspicion as to why or why not the treatment may or may not work. Next slide. So with these ideas of futility in mind, I want to start to turn us to considering how futility might be used in psychiatric treatment. And in particular, Daniel and I will be talking about it with reference to working with individuals who have something called severe and persistent mental illness. And this is really where we've focused our thinking about futility in psychiatric care. Next slide. So severe and persistent mental illness refers to a certain kind of patient experience. So severe mental illness is defined as mental, behavioral, or emotional disorders resulting in serious functional impairment, which substantially interferes with or limits one or more major life activities. And severe mental illness can apply to a point in time. So you could have an episode of illness where you're experiencing severe mental illness and you recover and it doesn't impact your functioning any further. Severe and persistent mental illness is a slightly different understanding. So individuals experiencing severe and persistent mental illness meet criteria for severe mental illness, but their experience of disease is that it's also chronic and always disabling. So they're not the individuals that necessarily just have these episodic illnesses that can recover. They instead have these persistent symptoms that continuously interfere with their ability to function in life or participate as fully as they may want to in different kinds of life activities. Next slide.
Thanks, Sarah. So futility as a concept in healthcare broadly is extremely controversial, and it has not been discussed really that much at all in the context of mental health. And given what Sarah has outlined, the question thus becomes for us is, should we apply concepts of futility in psychiatry? Or at least may some treatments for some cases of severe and persistent mental illness, may they be considered futile? So where we've seen some discussions of futility in the mental health literature pertains to anorexia nervosa. And this is largely because of the strong physiological component to the diagnosis. But perhaps healthcare professionals may be applying futility when they use other language in mental health. For example, if a condition might be considered treatment resistant, right? And what that means. Or sometimes you might hear people talking about a non-responder to treatment. Now, we can discuss sort of the stigmatizing implications of some of these labels. But perhaps implicitly here, or are healthcare professionals referencing concepts of futility when we discuss these kinds of conditions in mental health? So for the next section of the talk, these are just some of the key points that I'm going to highlight. So we're going to talk about clarifying some current concepts around what might be considered a fatal condition versus a terminal condition in the context of mental health. We'll talk a bit about the dynamic risk-benefit ratios in terms of decision making. And I'll also highlight some potential challenges to applying concepts of futility in psychiatry, and that has to do with capacity as well as concepts of recovery as well as various recovery approaches. So our first claim that we're going to make today is that futility applies because serious and persistent mental illness can be a terminal condition. So what do we mean by that? So futility as a term, as folks on the call are probably more familiar with, it has to do around end-of-life decision-making. So for example, when the patient has a condition that may unto itself bring about their death. However, in psychiatry, in some cases, or in mental health broadly, some have argued that futility should actually be applied in cases of terminal mental illness, a state which in part can be determined by the patient. But there's an inherent sort of conceptual challenge here, because what a terminal illness means does lack a lot of conceptual coherence in any area of medicine. But if we do look to some of the literature, in particular some systematic reviews or scoping reviews or thematic analyses of the concept of terminal illness, what we find is some unifying themes. So in particularly a presence of a progressive and irreversible disease with a limited prognosis, so without a shared defined time frame. Now, one question that might be coming up for some of you in your minds as well, is mental health sort of progressive and irreversible? And this comes up sometimes in context of irreversible or perhaps also irremediable, and this does come up in context of medical assistance in dying in mental health, a concept which we're not going to talk about or address today in our lecture, but it does raise questions about whether mental health can be irreversible. And what we want to do here for our purposes is also distinguish terminal illnesses from end of life. So the way that we're rethinking the concept of terminal illness is that it can be distinguished from end of life care. So a terminal illness in the case of serious and persistent mental illness is consistent with our understanding of individuals experiencing SPMI as having a chronic course and ongoing experiences of disability or impairment. We might see this in both psychotic as well as affective disorders, where there's repeated unsuccessful treatment trials and longer symptomatic periods that sometimes suggest an increasing risk of not just illness episodes, but also a decreased likelihood of symptom remission. And so on our account, this suggests that serious and persistent mental illness can be, perhaps in some cases, a progressive condition, and that has potentially refractory symptoms, resulting in what might be considered a limited prognosis. Now, this does not necessarily mean that the person is at the end of life, but may have, again, a progressive condition with symptoms that are refractory often to treatment. So I think what's also helpful to clarify here is to distinguish between fatal conditions and terminal conditions. So just to strengthen our assertion that some cases of serious and persistent mental illness may be considered terminal. So we might think of a fatal condition, for example, as a kind of natural kind that can be applied to any sort of given instances of an illness. So, and we will contrast this with a terminal condition, which we will call socially mediated. And so, for example, if a patient arrives at a hospital with a condition that will be fatal unless they accept a blood transfusion, right? Whether or not that condition becomes terminal depends on whether the transfusion is accepted. So there might be a sort of an agential quality here, or acts on behalf of the patient, which determines this situation. So the idea of what might be considered a terminal condition becomes really important when we're considering if we can apply the idea of futility in psychiatry. So given that it's solely not based entirely on the disease process, we might be able to conceptualize that some serious persistent mental illness might become a quote-unquote terminal condition if either the patient or the clinical team feels that there is sufficient evidence to conclude that the patient's life may perhaps be no longer recognizable to them because of their condition, and perhaps in some cases that might be a wish for death. Now, one thing I want to be very cautious and careful about is the very real issue of people who are living with serious and persistent mental illness and internalizing very sort of oppressive social attitudes towards people living with mental health, or various social and structural determinants of health, which might also contribute to the quality of life. And we'll touch on this a little bit later in the presentation, but I think these are sort of important nuance points to distinguish and separate out a bit in terms of patients' own or service users' own evaluation of their own quality of life. But if we can begin to sort of recognize that there might be some situations within mental health, so some terminal conditions within mental health, that we might anticipate that death could be a potential consequence of their condition. So, for example, the combination of biology and other various sort of intersecting social factors, then we may be able to consider that concepts of futility could potentially play a larger role in terms of how we're considering our ongoing treatment philosophy as practitioners. So we believe that some cases of serious and persistent mental illness may be considered a terminal but not fatal illnesses. And we do know from epidemiological research that people who live with serious and persistent mental illnesses have much higher mortality rates, and this could than the regular than the population that does not experience serious and persistent mental illness, and that could be for a whole host of factors, including the chronic course of many treatments with sort of very increasingly burdensome side effects that can result in organ damage, metabolic disease, other things, and so adding to this, serious and persistent mental illness being a progressive condition with potentially refractory symptoms leads to a limited prognosis. So I'm going to read the quote here that we have from our paper and how we're defining this here. So terminal illness in psychiatry can be understood as a condition in which ongoing interventions do not produce meaningful change in symptoms such that a patient deems their quality of life is unacceptable. The concept of terminal illness can be applied to serious and persistent mental illness, fulfilling the implicit assumption that futility might only be discussed and applied in terminal illness. So one thing I want to highlight here is that this is a treatment may be considered futile, or a condition may be considered terminal based on the patient's assessment of their quality of life and whether or not the ongoing interventions is producing something that they find meaningful to them. And we'll talk a bit more about this. But the idea, of a terminal illness in psychiatry, this is not just our conception. There's been some really interesting work that's been done in Switzerland. So, for example, Traxel and colleagues surveyed over 1,300 Swiss psychiatrists about the care of serious patients or people living with serious and persistent mental illness, as well as potential palliative care approaches. And what they found was that there was actually some pretty broad agreement that serious and persistent mental illness can be terminal, so like pretty close to 94%, and that some potential curative approaches may sometimes be futile. So, and in one case, so this was a vignette-based survey, and in one of the vignettes, which included anorexia nervosa, almost 72.5% of respondents believed that curative approaches in such a condition may be considered futile. And furthermore, I think what's important also for this discussion is that 75% of respondents believed, or actually were in favor, I should say, of palliative approaches for serious and persistent mental illness. And I think what this highlights is that in this sample of psychiatrists in Switzerland, they prioritized, things like reducing suffering, and that increased symptom management as primary goals of treatment is consistent with the conceptual finding that actually many of people practicing in psychiatry and in mental health might already align in terms of a palliative philosophy of care.
So building on that, and Daniel already started to mention it, we also were thinking about futility as applying in psychiatry, not only because these conditions could be considered terminal illness, but also because of something that we call the dynamic risk-benefit ratio, which Daniel started to touch on in terms of most of our treatments come with side effects, and how do we start to calculate the risks and benefits of these treatments as individuals progress in their illnesses. Next slide. And so to articulate this idea further, we wanted to introduce the concept of something called the risk of unacceptable badness, or the RUB. And this is a concept that we have found really useful, that was developed by Gillette, which says that the risk of an act that defines the RUB as the risk of an action resulting in a present or future state of living that the patient would themselves consider unacceptable. So essentially, it begs the question of, do some of the interventions that we can offer result in, even if they were to result in a reduction of symptoms or some remission, also carry with it some other unintended consequences that the patients consider unacceptable. And again, just to remind people that something we have to think very carefully about when we're evaluating the RUB of different treatments is also this idea of self-stigmatization for individuals living with severe and persistent mental illness, and how they might consider their own quality of life given some internalized oppressive attitudes that they may have been socialized to because of how we look at mental illness in our society. Next slide. So to explain a little bit more about how futility ties into that, Daniel's done a really nice job of describing how terminal illness in psychiatric practice isn't linked to end of life, but rather to where someone's at in the progression of their disease. And because our interventions are not necessarily there to extend life, but rather to reduce suffering and to reduce symptom, the question of if an intervention is futile in psychiatry is not determined by how much more time someone has left to live, but rather whether or not it's going to help us achieve those goals. And part of the rub comes in that because they're not necessarily life-extending treatments and patients don't necessarily have years of their life taken off by their mental illness, so that's kind of a contested idea. The side effect profile of a lot of our interventions actually matters a lot more in psychiatry because patients could potentially be living with these side effects for many, many years. So negative side effects should certainly play a role in determining futility in psychiatry. We have very good evidence to suggest that when treatments fail, further subsequent treatments are less likely to work. We know that in affective disorders, we know that in psychotic disorders. So given that we know that with every treatment tried, there's a diminishing benefit, yet the side effects stay the same and people are potentially living with those side effects for many, many years, we have to start taking that calculus and that shifting of the scale in the risk-benefit ratio into our consideration of futility and helping patients understand how that dynamic is changing and how that ratio is changing. And so they can use their own values about what kind of interventions might help them live versus simply be alive. Next slide. And the reason why this is really important to start acknowledging with our patients is that individuals experiencing severe and persistent mental illness are at risk of receiving overly aggressive interventions. Because we don't necessarily have a way to reorient our care in psychiatry as of yet towards a more palliative approach, there's this persistence in treatment where it feels like you might just be compelled to offer more and more and more treatments. But as you're doing that, you're also stacking up side effects. And I don't just mean from pharmacologic treatments. There are very much side effects associated with psychotherapies, for example, people having to relive their traumas or other sorts of adverse experiences that they may have had in their lives. There could be side effects considered as like an intrusiveness into someone's life. Let's say you're taking a very assertive model with patients and they have all these clinicians who are involved in their care where they more highly value their independence. So there's really this risk of giving people overly aggressive interventions that does not benefit their quality of life. Next slide. So I think in the context of the dynamic risk-benefit ratio and knowing about this idea of the rub, it really helps to understand the idea of futility in psychiatry as a potentially inappropriate treatment. So again, that's not to say it's going to have no physiologic effect or not change anything at all, but rather at this point in someone's illness, does the intervention I'm proposing remain an appropriate treatment? And one way that we can start to frame that is to consider applying staging models to communicate information in psychiatry, the way that other medical illnesses use staging, because staging can really tell someone about the likelihood of response, the course, where they're at in their course of illness, and also the appropriate treatment options. And as we've talked about, we need to consider side effects in these futility judgments to mitigate that risk of unacceptable badness. And we're really hoping that as the concept of futility is developed, it can become a collaborative judgment between clinical team members and patients so that there's really this multitude of perspectives to try and understand where the patient is at and how we can best help in the situation, which may mean actually backing off of interventions that could be considered futile. Next slide. Now, there's a couple of challenges to the application of futility in psychiatry. And probably the most common challenge, and this comes out of the anorexia nervosa literature, is that is the idea that, well, people who are experiencing illness that's severe often may not have insight into what their symptoms are, and it's unclear if they're always capable to consent to treatment. So that means that they're unable to understand or appreciate the implications of treatment. And given those two deficits, can futility be applied? Because you could just keep giving them treatment in the hopes that their insight would develop and they become more capable to consent and adhere to treatment, and then they would do better overall and they may experience more symptom reduction. We actually argue no, we don't think that issues of insight and capacity should preclude the application of futility in psychiatry, and I'll explain why on the next slide. So there's two ideas that are represented here. So the first being that a lack of insight and a persistent sort of lack of understanding and appreciation with respect to interventions may be a marker of severity of illness. So just like a certain level of kidney function or a certain level of breathlessness on a stress test may be indicators of severity of kidney disease or heart disease, such that certain interventions are no longer appropriate. If someone has a persistent lack of insight, that may be a marker of severity of illness in someone's mental illness, such that certain kinds of treatments or interventions may no longer be appropriate. And that actually includes the finding of incapacity itself. So when we make a finding of incapacity, it's to help compel someone towards treatment. We have all sorts of different ways, at least in Ontario's jurisdiction. In other jurisdictions, there are other ways that when someone's incapable to consent to treatment, we can sort of force treatment upon them. And one starts to question the utility of doing so if you're not able to offer any new treatment. So we talked about that dynamic risk-benefit ratio. We talked about how that could affect someone's quality of life overall. So you can start to question, is it actually useful to continue to find someone incapable to consent to treatment if we don't have anything new to offer? Or is the finding of incapacity itself no longer a helpful intervention in terms of advancing someone's care, providing comfort or symptom reduction? So for these reasons, neither the issue of insight or capacity should represent too much of a challenge to futility. Next slide.
Sarah, just letting you know it's
Yep.
4:40. Thanks.
And again, the risk of these repeated findings are the overly aggressive treatment, intolerable side effects, and invalidation of patient suffering and self-identity. Next slide.
So another claim that we want to make is actually futility, or naming futility in the context of mental health, can actually advance personal recovery. So recovery is critical and essential to mental health care. But what we want to distinguish is two different types of recovery. First is clinical recovery. So this is when in any area of healthcare where there's a cure for treatment or sort of ongoing illness management, right? So for example, you break your arm, you have the necessary treatment, the bone heals, that would be considered clinical recovery. But personal recovery, I think, is actually the more important and sort of morally important aspect of recovery, and is also in mental health in general, but also relevant to our discussion. So personal recovery is defined by the individual. And this is how the person defines that they are functioning, at their best given their symptoms. And we acknowledge that within futility, that the ongoing interventions itself in mental health can actually interfere with a patient's notion of personal recovery. Now, so to hold the idea of futility as being antithetical to personal recovery, we think this is a false dichotomy. And actually, in this way, it also highlights sort of the ongoing and iterative nature, if you will, of the concepts of futility and of recovery, that it, as Sarah mentioned, that it applies to wherever the person is in whatever their stage of illness. So this, is not a fixed idea, and this is something that is constantly being negotiated and discussed, ideally in a safe treatment or context. So we actually think that futility can be helpful in promoting personal recovery by delineating the limits of psychiatric intervention, sort of creating a space for the co-construction of treatment narratives between service users and their healthcare professionals. And we actually hope that futility can also be a signpost that, you know what, we need to realign our treatment philosophy and our care to fit with patients' priorities as their illness progresses. And, you know, I think it also can help as in terms of naming futility and saying, you know what, we have to have a frank discussion about the ongoing realities of ongoing treatments that are not evidence-based or perhaps beyond sort of the evidence-based guidelines and are potentially harmful. So futility maybe is, you know, actually in our conception of futility here is that it's a indicator that things should change, that our philosophy or our treatment approach should change. So just, you know, briefly in summary, the use of futility here, we're using it as support that some cases of serious and persistent mental illness may be a terminal condition. It can help clinicians and service users, patients also avoid the rub or the risk of unacceptable badness. And we don't see issues of capacity and recovery. We don't think they should be barriers, actually, in terms of the importance of identifying futility and in the care of patients experiencing serious and persistent mental illness. So what this calls for and what we're keen to explore is, and what Sarah has been alluding to, is the idea of a palliative care model for psychiatry. So this is not necessarily palliative care for people, palliative end-of-life care for people experiencing mental illness, but rather a treatment philosophy and approach. Because we know that people who are living with serious and persistent mental illness are, you know, at risk of issues around therapeutic neglect, overly aggressive care for many, many reasons. We can see how this model may actually advance personal recovery, and we can see how this model can apply in psychiatry, and I'll explain what it is in a moment. So getting back to some of the work of Traxel and colleagues, they were motivated to develop a model of palliative care because there were really no existing best practices when it comes to determining a clinical course when cases of futility came up. So perhaps this model might fill this gap. So palliative psychiatry is, as they define it in their working definition, is an approach that improves the quality of life of patients and their families in facing the problems associated with a life-threatening, severe, and persistent mental illness through the prevention and relief of suffering by means of a timely assessment and treatment of associated physical, mental, social, and spiritual needs. Palliative psychiatry focuses on harm reduction and on the avoidance of burden, some psychiatric interventions with questionable impact. So, you know, I think this is really important, again, seeing how futility fits within this broader model and signaling a need for a palliative approach, moving to more of a compassionate, comfort-based symptom management approach. So, you know, futility, again, as I mentioned earlier, is a moving target. It's not stagnant. You know, we do hope for treatment advances, and we very much call and advocate for an increase in the structural improvements in the structural determinants of health and compressing health inequities, particularly around things like housing, which we know have a huge impact on the quality of life. But that we need to understand futility within this context. You know, we need to understand futility in the context in which patients are situated. As we've noted a few times throughout, we do not think that, you know, we have to be very careful of ideas of people internalizing self-stigma and internalizing oppressive attitudes that may impact on what they think their quality of life is. And also that something should not be considered futile in this case if it's perhaps futile due to the social determinants of health, for example, lack of housing. And the sort of a final point I want to emphasize is that, you know, futility has a lot of baggage, and even palliative care as a concept has a lot of baggage. But futility does not justify an abandonment of care, and that's not what we're talking about at all. It's the reorientation of care, because it's a different type of care, and there's lots lots can be done, and especially around a compassionate symptom comfort-based measures in caring for and with people living with severe and persistent mental illness. So here's just some of the lists of the works that we cited today in our presentation, and thank you all very much for listening.
Wonderful. Thank you so much, Daniel and Sarah, for that thought-provoking presentation. A number of questions and comments have come in, both on YouTube chat and also anonymously. And just for those who are in attendance, please do type any questions and comments into the chat, and then I'll gain access to them and read them out to our presenters. And if you do want to submit an anonymous question, you can submit them to Lori Bulchak, and she has input her email address into the YouTube chat. And so I'll just start off by reading one of the first comments that was made, which is around this concept of chronic and always disabling, which I think was mentioned towards the beginning of your presentation. And it's just noted, and this was submitted by the Ontario Association for ACT and FACT, that chronic and always disabling is not a common or accepted definition. And so I guess this is just looking for your thoughts on that idea.
Yeah, I would agree that it is very hard to find a consensus definition of severe and persistent mental illness. That definition is taken from SAMHSA, which is an American organization. And again, I think this is where some of the social and structural supports that actually modify a lot of how someone's course of mental illness kind of comes in, because I think they do also operate in a different healthcare system that has different kinds of interventions than we do. That was the definition that was most commonly used across the other literature on futility in psychiatric practice, which was albeit limited, but I completely agree that it is a contested definition, and that it is perhaps not always in keeping with, again, that idea of both clinical and personal recovery that we try and promote in that type of work.
Thank you. Okay, and then there was a comment that was sent in by an anonymous attendee, and a very, very similar comment was also expressed by the same Association for ACT and FACT, which is this idea that regardless of whether a particular treatment works, natural adaptation, learned coping skills, reduction of social stressors, and new purpose and meaning, it can occur at any point in the illness trajectory. So I guess just looking for a comment around your thoughts, this idea that these sorts of things can occur at any point.
I can start by speaking to it. I'm curious to hear Daniel's thoughts as well. Yes, again, and I think that's why we really tried to emphasize in the presentation that futility judgment should not be stagnant, and probably no judgment around where someone is in their clinical course or what is possible for them should ever be stagnant. What we're really hoping that people could take this concept to use is at certain points in someone's illness, if they're expressing their own sort of dissatisfaction with the kinds of interventions that are being offered, or they're expressing their own dissatisfaction with their quality of life, that this could be a useful clinical concept to help reorient care to be more in line with their goals. And I think that's where emphasizing that last point that Daniel made, that futility is not antithetical to the idea of personal recovery, which is where we talk about the meaning that people might find at any point in their course of illness or at any point in their life, is really, really, really important to remember. So this isn't, like Daniel said on his last slide, this idea isn't there to justify like an abandonment of care and say nothing's ever going to work and you're just kind of stuck living like this. It's still helping. We want to introduce it as a clinical concept that can actually help push people's care forward in a way that's in alignment with their goals and alignment with what feels meaningful to them at that point in time. And it's just like another clinical tool to help do that.
Yeah, I mean, I don't have too much to add. I think thank you for the question and the comment. I think we also want to emphasize that when we're thinking about futility, it's not only about pharmacological interventions, and that we acknowledge that, I mean, Sarah mentioned this as well, but that, really we're looking at this holistically, and that, the importance of factors, psychosocial factors that contribute to individual well-being, and that can help, again, people achieve meaningful personal recovery, housing, contacts, you name it, various things that matter to people, and really sort of centering the service user in that and helping them achieve things that matter to them, is really our goal, with sort of compassion as a value underpinning all of this.
Thank you for that. Another question came in, and it's anonymous. This person says, thanks for this presentation. I wonder if the presenters could share whether they have thoughts on how futility within the context of SPMI could be wielded against BIPOC with SPMI, so Black and Indigenous people of color, given what is widely known about disparities in care, disparities in access, racial discrimination in hospitals, and how traumatic the experience tends to be for Black and Indigenous people in particular. I wonder if the presenters could comment on how discourses of futility could work as an additional barrier, or might work to disproportionately impact BIPOC and might hasten a pathway towards palliative care.
Sarah, do you want to go, or I can jump in?
You start.
Okay. Thank you very much for the really important question. So I think, like many other aspects of healthcare, Black and Indigenous people of color suffer disproportionately in the healthcare system, in the mental health care system. There is, there's ample evidence and personal experiences of inequitable care, poor quality care of care, and so we worry that any aspect of healthcare could be used against a person. And I think with anything, I think there is a risk of that. One thing that we mentioned is, so not only is it the internalized sort of notions of meaningful lives or quality of life amongst the service user or the patient, but also from the perspective, I think what this is getting at perspective of the healthcare teams, against either unconscious or conscious racism, bias, and discrimination against certain groups. And so, we would hope that sort of any potential application of thinking about futility as moving towards a compassionate approach that's centered on the person's values and what matters most to them, has this in mind, and is very conscious around the structural inequities that do exist in mental health care and in healthcare in general, and is not sort of even used unconsciously in a way that would sort of consider as someone as not receiving treatment that might be consistent with their values and is sort of more of the team's values. So we would hope this would be a negotiated discussion, but I think it's a very real issue in all aspects of healthcare, and that futility as an F word, as a term with a lot of baggage and history, sort of is not, and I'll say, weaponized in a way that disproportionately harms BIPOC communities.
Thank you for that. So a comment that I think has a question incorporated comes from Ryan Tanner, who expresses a concern about diminishing benefit of treatment steps, and says that it's a super important notion in the debate about medical assistance in dying and mental illness, which gets ignored. I guess this idea about diminishing the benefit of treatment steps. So if you could comment on perhaps your notion of futility and how this may relate to the debate about MAID and mental illness.
Yeah, thank you. I mean, we have spoken a lot about this because, I don't think either, we didn't write this paper focused on, and we didn't think about these ideas focused in the context of the debate on medical assistance in dying, but obviously it's highly relevant to it. And I think, again, to sort of reiterate that idea that we're hoping that a clinically relevant concept of futility would really take the patients' experience or service users' experience into account and really be at the center of everything. So I think as clinicians, our job is to make sure that those individuals have all of the information, that they understand, that when we're kind of going off guidelines, going off evidence, that it's in keeping with their goals. And we've talked a lot about it. I don't know exactly how it would apply to MAID because I don't know how the legislature is actually going to be written and how it's going to come out. But again, we would hope it would be applied in the context of being consistent with the patient's goals for their own personal recovery. And also that futility wouldn't come to mean, okay, now the option is made. That, again, to emphasize that concept that futility is not about an abandonment of care or proceeding necessarily to this concept of end-of-life care, but rather a signpost about a reorientation of care in terms of how can we help individuals achieve their goals, achieve what they themselves consider a meaningful quality of life or meaningful activities of life, and use this concept in that way. So I know that isn't like the most satisfying answer, but I really think that we have to keep the patient's perspective at the center of all of this, and they themselves could decide how that might apply to their understanding of where MAID would fit in for them.
Thank you for that. And recognizing we have one more minute, maybe we'll just try to sneak in a very quick question, if that's okay with you both, which is this idea that, you define terminal illness in psychiatry as something that's understood in which ongoing interventions don't produce meaningful change regarding quality of life. And just wondering if you are only referring to interventions that are clinical, or whether you might also be thinking about interventions that respond to social determinants of health, like housing or financial gains, these sorts of things.
Quickly, I'll just say that we're thinking of it beyond including but beyond pharmacology. We sort of looking very holistically at the person's care and their experiences of care and what matters to them, and is the ongoing approach that they're receiving, or the treatments that they're receiving, and again, using treatment very broadly, is this contributing, no matter what it is, to a life that people find meaningful and that they feel that they can flourish as much as possible, and that does contribute to their personal recovery. Sarah, I don't know if you want to add anything to that. So yeah, I think we look at the whole gamut of types of activities, if you will, that are happening around the person's care.
Thank you. Okay, and recognizing it's 5:01, I think this speaks to how thought-provoking your presentation certainly was. It is time to draw today's seminar to a close. So I have a couple of announcements to make before we thank our speakers. Our next seminar will be on Wednesday, March the 10th, where Tegan Kalaki will be discussing advanced care planning in advanced chronic disease, an exploration of relational autonomy. And for those who want to sign up to receive our weekly seminar reminder emails, please email jcb.info@utoronto.ca. And CSB students who are enrolled in the CSB Student Seminar course, please remember to keep track of your attendance. And Daniel and Sarah, on behalf of all of us here, thank you very much for your insightful presentation.
Thanks very much, Andrea.